points. First, Dr. Saravanan will talk about AON as he is going for another session as a judge.
Thank you, sir. Slides. Yeah, thank you. So this is quite a common scenario which you notice when you're doing medical retina practice. And first question is, when you see a disc edema, what are the DDs to think about? But I'll mainly be talking about AON, and in the following speakers will enlighten you on how to differentiate between all these entities. So as you know, this is very commonly seen in the old age group. And when we have multiple risk factors, systemic risk factors, diabetes, hypertension, cholesterol, heart disease, and all those things. And most common thing what we see is the non-arteritic type, which is a little bit less aggressive compared to the arteritic type, which is much more rarer. And we don't see that very often, but you need to keep that in mind. And in case you have better to refer to a higher center because these patients need a lot of long-term follow-up also. As I told you, the vision can be usually is what we see in our practice is that the vision in these patients with the non-arteritic anterior ischemic optic neuropathy is usually 660 or less. Occasionally, you can have patients who have vision better than that, but most of the times, if you have vision more than 660 or 636, keep other DDs in mind before you narrow it down to a NAON. So this is just a few case examples. This patient actually came a little bit late after around 6 weeks of vision loss. And we noticed that he had disc pallor and RAPD in the right eye, and he was a known hypertensive and not on continuous compliant treatment. He was a little bit irregular in his treatment, and he was complaining of altitudinal field defect. As you can see here, the left eye, it has got a very small cup or no cup in the left eye, but the right eye, when you notice, you can see that the inferior disc is a little bit more pinker, but the superior half of the disc is much more paler, with also some arteriosclerotic changes, which is maybe because of his hypertensive retinopathy. So this case, then finally we worked up, and all cases, first you rule out that the ESR is normal, and in case you are doubtful, always do a CRP. And because he was a known hypertension, he also had cholesterol also. So we didn't further investigate him because of old patient, and we just treated him conservatively. This is one more case where I failed to identify the patient's diagnosis. A young patient who's coming with had mild hypertension, mild dyslipidemia. And he came to us with the one disc. He had around 260, 360 vision in this eye when he came. Left eye was a small disc, and the right eye was, you can see, as you see, you can see the pallid disc edema. Look at the margins, you can see the pale color. So this is a pallid disc edema on one eye, and in a very young and healthy person who's got a very mild systemic or a very low risk factors, mild hypertension, mild dyslipidemia. So unfortunately, even though I referred him to I was sure that I was missing something, so I referred him to the internist, medical specialist. But unfortunately, they didn't pick up any systemic disease at that point of time. But he came after around 1.5 to 2 months with the other eye involvement. Again, vision dropped to around 460, 560. And then I referred to another physician, and they diagnosed that he had a factor V Leiden deficiency. Unfortunately, I felt so bad because I had missed it around in the first sitting itself. But there can be unusual reasons in patients with the anterior ischemic optic neuropathy, especially when you feel that the risk factors are not pertinent enough to cause such a big manifestation in the fundus. So always keep other rare DDs in mind when you are dealing with these patients. So almost always, depending on the vision acuity loss, you will have a disc edema and RAPD. And usually field defects are altitudinal, but not always so. So don't give too much importance to the altitudinal field defect. You can get irregular fields or very poor vision where the patient is not able to see the fields also. So a significant number of people, around 1/4, will have some sort of pain in the eye or the head, which can be a little bit confusing with the optic neuritis diagnosis. But again, there are other factors where you can narrow it down. So one thing which can a little bit mimic NAON is amiodarone. I have seen one case of amiodarone optic neuropathy, which I wrongly diagnosed. But the disc edema was persisting for, normally in AON, the disc edema will resolve within 3 to 4 weeks and pallor will set in. But this case had persisting edema, and finally, after reading up, we finally diagnosed that patient was on amiodarone, and it was the reason for this neuropathy. So when you do fluorescein, normally it's more of a clinical diagnosis, but occasional cases where you're doubtful, you can do a fluorescein angiography. And in the fluorescein angiography, like in this case, when you see, you can see the superior black area, meaning that the disc is not filling up in that area, and that's why the patient also get a 6 altitudinal field defect, as you can see here. So this is the corresponding altitudinal field defect, and once it resolves, it will go on for a pallor approximately 3 to 4 weeks. After definitely after 6 weeks, you will see that the pallor is already set in. Any edema persisting more than a month, be wary of a diagnosis of NAVN, but it's not usually AVN at all. So if it's persist. There's one more case of so you can see typical superior disc, half of the disc is pallid disc edema, and fluorescein is showing the filling defect. It's a diabetic patient, again a case of NAVN. So in OCT, normally you will not see macular edema in these patients, but a small percentage of people can develop peripapillary thickening, papillomacular bundle area thickening, and sometimes a small SRF in the macula, but it's not common. So in case you have a significant macular edema or SRF in the macula, think about other inflammatory DDs, which should probably be discussed in the coming speakers. So you can see here the disc edema in this patient. The OCT is showing the disc edema, and you can see the papillomacular bundle area edema, as well as a short, small SRF in the fovea. But this is not a common finding in AVN, but occasionally it can happen. So one other DDs which you commonly confuse is the optic neuritis, and you can see that the field effects are not usually opposite to each other. And the thinning which you notice in the optic neuritis also is a little bit different from what you see open angle glaucoma, and what you see in the NAVN are totally different here. So this is a case of resolved bilateral NAVN, the light in the NAVN, and you can see the OCT angiography shows the loss of the capillaries on the surface of the disc. Compare this to the left eye, and you can see the right eye that surface capillaries have lost out. So sometimes OCT angiography also will help you to clinch the diagnosis. So this is a case of a young female who came to the disc edema. Again, somebody had diagnosed, because the patient was already hypertensive and diabetic. They are diagnosed NAVN, referred to the clinic. But you can see here that there's a small NVD, and also you can see the cystoid macular edema pooling in the late phases with multiple areas of perivascular leakage in the periphery. And if you do the OCTA, you can see the NVD sitting there. So when you see NVD, it's usually almost always inflammatory disc edema, and this patient turned out to be a sarcoid patient, and then went on for a steroid therapy also. So the other things to when diagnose AVN is to rule out the cause, because treating the cause can prevent the occurrence of such eventuality in the other eye also. So common causes are like disc at risk, which you see, and apart from that, the routine vascular diseases like hypertension, diabetes, sleep apnea, and post Viagra, a few cases have been reported, and hypercholesterolemia. So all these can be risk factors, and addressing these risk factors will go a long way in preventing the same occurring in the other eye. Other rarer causes to keep in mind when the routine workup turns out negative is all these inflammatory diseases of the vessels, and also factor 5, which I missed out and I showed in one of the cases. So blood count, routine blood count, and is enough in routine old patients with other significant risk factors. But if you're seeing young patient or unusual finding, always work for other immunological diseases also. And first thing you have to do is always ESR and CRP if needed to rule out the artery type. Because if you're seeing artery type, the treatment is going to be totally different actually. So this is just showing the difference between a normal disc and a disc at risk, how the difference is. So the disc at risk means that the other eye is also at a higher risk of developing NAVN. So the treatment as far as NAVN is concerned is not very great, as till now we don't have a very proper treatment for this. And the decompression trial, they showed that it was not very helpful. Initially there was during my PG days there was a lot of interest in the decompression for NAVN, but again it turned out to be not very definitive treatment. Right now we don't have any treatment, but addressing the systemic risk factors and probably taking aspirin also can help preventing the other eye getting affected. In artery type, the picture is a little bit different. You have significant systemic symptoms, and it's usually a little bit more higher age group, as you can see here. And the disc edema is much more profound, like you see in this patient. And you can see the presence of jaw claudication, malaise, sometimes myalgia, sometimes mild fever also can be noticed. So normally we to clinical diagnosis, previously we were doing the temporal artery biopsy, and usually the ESR and CRP are quite high. But recently, the MR imaging of the temporal artery vessels can also pick up within a non-invasive way. The specificity of this test is almost 90%. So if the MRI of the temporal artery is negative for occlusion, then usually it's not temporal arteritis. So now the artery type, without the necessity of doing a temporal artery biopsy, now MRI imaging of the temporal arteries scalp arteries and intracranial arteries also can clinch the diagnosis in these patients. So in case you diagnose this, better to refer to a higher center, because ophthalmology we don't have that much of the backup to treat them, because the treatment can go as long as 1 to 3 years or more than that also. So high dose steroids initially, followed by non-steroidal immunosuppressive drugs like methotrexate and other things need to be addressed in these cases. I'll stop here. Thank you for the opportunity, sir.
Thank you, Dr. Saravanan. Dr. Saravanan is the head of VR department at Aravind Coimbatore.